Hello everyone, I'm Bryan Miller and I'm Director of Scientific and Technical Operations at Crown Bioscience UK. And today I'm going to be discussing how in vivo imaging approaches can add value to your drug development programs. The talk is going to cover the value of orthotopic and metastatic models in oncology research. It will discuss the establishment of clinically relevant oncology models using optical imaging. I will then discuss the advantages of using high-frequency ultrasound for establishing orthotopic cancer models. And in the final section, I'll discuss the use of MRI imaging with orthotopic tumor models. So orthotopic and metastatic models of cancer allow a better understanding of the mechanisms of disease. They allow us to investigate the contribution of organ-specific tumor microenvironments to treatment responses. You can study the development of tumor-relevant vasculature. You can study the interaction between the tumor and the stroma. It also allows us to study environmental pressures and also TME targets. Using these models allow us to evaluate disease progression from early tumor to development, to local invasion, to distance migration. And these approaches can be used to understand metastasis and also study advanced stages of disease. So there are a number of benefits of using imaging modalities in vivo research. Allows quick and real-time tracking of disease progression without the need to sacrifice animals at earlier stages. It allows less invasive methods for tracking tumor growth and disease progression. And it gives options for less invasive approaches for the generation of in vivo models with improved survival. For instance, through the use of ultrasound-guided injection. So for the next few slides, I want to discuss the establishment of clinically relevant oncology models using optical imaging. So at Crown, our optical imaging is performed using an IVUS in vivo imaging system. And this has a number of benefits. It expedites progress towards clinical trials. It has measurable economic benefits, including reduced animal costs and personnel costs. It allows simultaneous insights into drug efficacy, kinetics, targets, and mechanisms. It also facilitates superior statistical analysis and reproducibility. So using these models, we can study disease progression from the primary tumor through to spreading into the regional lymph nodes through to distance metastasis. So what I'm going to focus on are imaging models of breast cancer, where we shall look at these different stages of disease progression. So the first model I want to discuss involves orthotopic implantation of breast cancer cells into the mammary fat pad. So the model we're using here is NDA-MB231, and it's labeled with firefly luciferase. We then perform implantation into the mammary fat pad, and we can then measure tumor growth either by bioluminescence imaging or by caliper measurement. We validated this model using docetaxel, and in the lower graphs on the left-hand side, you can see the strong inhibitory effect that docetaxel treatment has on tumor progression. And this is data collected by bioluminescence imaging. In the middle graph, this is looking at tumor volume measurement by caliper. And you see there's very good correlation between the BLI data and the tumor volume data. And we've also validated this by measuring tumor weights at termination, which is shown in the right-hand graph. This model can also be used to measure the development of spontaneous metastasis. So this can be done with two main approaches. You can do some metastatic measurements in the live mouse, and there's some data shown in the top right hand of the slide. And we can also do metastatic measurement ex vivo. So when the mouse is terminated, you collect the organs, you then measure bioluminescence with each individual organ as a measurement of metastatic spread. And with the MDA MB231 model, we find metastasis in 93% of lungs, 70% of lymph nodes, 40% of mice have metastasis to the liver, 27% have brain metastasis, and 20% have bone metastasis. So in order to focus specifically on metastasis, we can use an experimental bone metastasis model. In this model, breast cancer cells, in this case MDA MB231, are injected directly into the heart and enter circulation. The mice then develop bone metastasis lesions. We can then use this model to test anti-metastatic therapies. And the example shown here looks at mice dosed with pamidronate. And as you can see, with the treated mice, the incidence of metastatic lesions in the bones is very much reduced. This data can also be further characterized using CT imaging approaches. So there's two movies here. The one on the left is showing mice which are vehicle treated. And in this instance, the mice develop metastatic lesions after 3 to 4 weeks. And they reach endpoint due to these lesions. On the right, this is a mouse that's treated with Taxotere. And this effectively inhibits progression of these lesions. And they no longer drive endpoint. However, what we do see in the treated mice is the development of brain metastasis. The therapy doesn't really cross the blood-brain barrier effectively, and so it's actually brain mets which drive the endpoint in these treated mice. So another approach we can take to measure breast cancer metastasis is to model late-stage metastasis by directly implanting breast cancer cells at the metastatic location. So in the model shown here, this is taking BT474 cells, which are labeled with luciferase, and then implanting them intracranially. This allows an assessment of therapies which are targeting brain metastasis. In the next section of the talk, I want to focus on the advantages of using high-frequency ultrasound for establishing clinically relevant oncology models. So high-frequency ultrasound has a number of benefits. It leads to improved animal welfare and survival. It allows tumor monitoring in real time. It gives you high-resolution images. It is non-invasive. It allows the measurement of anatomical and physiological parameters. It is excellent for soft tissue imaging, and the data is also translatable to patients. So, for use in cancer research, ultrasound allows tumor detection. It allows tumor sizing in either 3D or 2D. It allows measurement of angiogenesis, molecular imaging, and you can create orthotopic models using ultrasound-guided injection. So this is an example of high-frequency ultrasound-guided injection into the pancreas. So in this case, we are implanting 2 times 10 to the 5 tumor cells in a volume of 20 microliters. The results are at least as good as traditional surgical approaches, and they're a lot less invasive for the mouse. So in the video, you can see the needle has entered the pancreas, and the tumour cells are dispensed into the organ. The advantage here is, that it does not require deep anaesthetic. There's no post-operative analgesia required. There's no scar, and it's higher throughput. And it's much, much better for the animals. Within about 10 to 15 minutes, the animals are up and running around their cage again, as opposed to traditional surgical approaches, where you can take up to an hour for animals to recover from the procedure. So this is data from one of our orthotopic pancreatic models, MP6115, which is a luciferase labeled model. This is run in C57 albino mice, and tumours were implanted by ultrasound guided injection, and 100% of mice developed tumours. We measured tumour growth either by bioluminescent imaging or by measurement of tumour volume using ultrasound, and the correlation between these two measurement approaches was very clear. And these are just some ultrasound images looking at tumour growth over time. So the images are taken on study day 8, day 15, and day 22. And you can see from the outline the way that you can monitor the growth of the tumour over this time period. And we validated this model using a standard of care. In this case, we use gemcitabine dosed at 40 mg per kg twice a week. And this resulted in a statistically significant inhibition of tumour growth, either measured by bioluminescent imaging on the left or ultrasound measuring tumour volume in the middle graph. And we also saw improved survival in the mice, which is shown in the right-hand graph. We can also take similar approaches for orthotopic implantation into the liver. And this slide is showing some examples of our HEP3B luciferase orthotopic model. In this case, 1 million cells were implanted into female CB17 skid mice. And like our pancreatic model, 100% of mice developed tumour. And as mentioned before, we saw very fast recovery of the mice from the implantation. So really, within 10 to 15 minutes, the mice were fully recovered from the procedure. We've also validated this model using standard of care, in this case, sorafenib. And mice treated with 50 mg per kg sorafenib really didn't display any tumour growth over the course of the study. Okay, so in the final section of the talk, I want to discuss imaging of orthotopic tumour models using MRI. So Crown Bioscience offers cutting-edge MRI technology to facilitate early detection of orthotopic tumours in rodents. And the MRI has a number of benefits. It allows high-resolution imaging to be performed. It's non-invasive, and it also allows the monitoring of longitudinal studies. So I want to just show some example data using an orthotopic brain model, U87MG. So these cells are labeled with luciferase, and tumours are established by implantation directly into the brain. And tumour growth is then measured either by bioluminescent imaging or MRI. And much like we saw with the ultrasound versus optical imaging, the correlation between BLI and MRI is very good. What we do find with this model is we do observe weight loss at the later stages, as shown on the right. So we've also validated this model with the standard of care, in this case, temozolomide. And the mice were treated with 10 mg per kg temozolomide once per day for 5 days, and this significantly reduced tumor growth. And this could be measured either using bioluminescent imaging or by MRI measurement of tumor volume. And we can have a look at some of the kind of raw imaging data from this model. So this is the BLI imaging data. So group 1 is just vehicle treated, and you can see over the course of the study how the BLI signal has increased in the brains of the mice up to day 21 when the model was sacrificed. In contrast, group 2 are treated with temozolomide, and you see very little tumor growth. And at the end of the study, there was very little BLI signal in the mice. And this is very nicely validated by also measuring tumor volume by MRI. So in this case, there are 2 mice, numbers 3 and 19, which are vehicle treated. And here the arrows indicate where you can clearly see the development of a brain tumor. In contrast, mice 12 and 15 are temozolomide treated, and there's very little tumor at the end of the study. And this is confirmed by the quantitation of tumor volume from the MRI images. So just to summarize, we have 4 imaging platforms available at Crown, each of which has distinct advantages. For bioluminescence imaging, this is high throughput. You can image up to 10 animals at once. It allows for rapid image analysis, and it's relatively inexpensive. High-frequency ultrasound can be used to guide tumor cell implantation and avoid complex surgery. It can give more precise measurement of tumor location compared to BLI. It allows 2D and 3D imaging with accurate tumor volume measurement. And there's no requirement for tagging your cells to enable visualization. MRI allows for high spatial resolution and multiparametric imaging of orthotopic tumors. Like ultrasound, there's no requirement to tag cells to enable visualization by MRI. And it's not limited by tissue depth or bone. CT imaging allows 3D reconstruction of a whole animal and can provide detailed information on biodistribution. Thank you for your attention today. If you'd like to discuss further in how imaging approaches can help your drug discovery program, please do get in touch with us, and we can give you more information about the approaches and the models we have available. Thank you.